Welcome. Today we'll be going over Chapter 37, Emergencies for Patients with Special Challenges. We'll be going over patients with special challenges, approaches to care of patients with special needs, general considerations in responding to patients with special challenges, diseases and conditions, advanced medical devices, and abuse and neglect. So patients with disabilities, when working with patients with special challenges, use empathy and respect. It can be difficult to know the correct terminology to use when working with these patients. The term disability refers to a condition that interferes with the ability to engage in activities of daily living. The term handicapped should not be used. A developmental disability is a chronic impairment beginning at the age up to 22 years. Things like cerebral palsy and Down syndrome. Other disabilities are the result of traumatic injury or a medical condition like multiple sclerosis, Parkinson's disease, stroke, or traumatic brain injury or spinal cord injury. Many patients live independently with accommodations. Some patients live at home but require special assistance, and others with more severe disabilities may live in an institutional setting. So that being said, when we're responding to patients' homes that do have a disability, it's good to verify that they have the accommodations that they need, whether that's a bar in their restroom to help get out off the toilet, the elevated toilet seats, that they have good access to the phone, food, drink, all that. When we have blind patients, there are times that they'll want to touch you. That's the only way that they can get some kind of visual on who they're working with. Patients with terminal illness. Terminally ill patients have conditions like end-stage cancer, heart failure, and Lou Gehrig disease or ALS. They may prefer to stay home under the care of the family with assistance from hospice providers versus going to the hospital. They know that they have a terminal illness and that the hospital may not be able to do anything for them. They may rely on technology to sustain life or relieve pain. Things like nerve stimulators, that kind of thing. Advanced directives specify the types of emergency care the patient will accept. So differing from a DNR, this is something that would have more specific end-of-life care. Maybe they choose not to be intubated or they choose not to have any artificial feeding, that kind of thing. Patients and their families both have special emotional needs. I know we've discussed it in class when we have a patient that does die in the field. We need to kind of shift our focus to the family. They are in need of support, so we try to shift our focus to them when that's necessary. Obesity. Obesity is a body mass index of 30 or more. There's a calculation there to figure it out. It's not really something we figure out pre-hospital, but if you ever wanted to, there it is. Once the patient is considered obese, they are at an increased risk for multiple diseases, and it is a significant growing problem amongst adults and children in the U.S. So some special measures to care for obese patients: allow the patient to assume a position of comfort. They've got a lot of body mass on their chest and abdomen, so if we laid them supine, for example, they may have a difficult time breathing. So whatever position of comfort, it's normally like a semi-Fowler or high Fowler position on the stretcher. Monitor oxygen saturation and provide oxygen and ventilator assistance if needed. You can use a ramp position to maintain an open airway. Use gentle pressure when ventilating. Have enough assistance to lift or move the patient. Be mindful of the maximum load of your stretcher. Just a little note here, bariatric surgery can result in post-operative complications and hypoglycemia. Do not be afraid to call for assistance to help you move these patients for your safety and the safety of the patient. Homelessness and poverty. Homelessness is a state of not having a regular place to live, often because of an inability to afford housing. Health problems in this population include pneumonia, mental health issues, malnutrition, substance abuse, and HIV or AIDS. Lack of access to care means that their conditions often go untreated until they become emergencies. Homeless women are often victims of abuse. Emotional problems are common in homeless children. Poverty is a common cause of homelessness that occurs when income is not adequate for the standard of living. Okay, approaches to care of patients with special needs. So for autism spectrum disorders are developmental disorders that affect the ability to communicate. This is a spectrum, so some are pretty high functioning. Some patients with autism are not as high functioning. Traditional assessment techniques and treatment protocols may need to adjust for a patient with autism. You can use the mnemonic ABCS when treating a patient with autism. Awareness, basic, calm, safety. So awareness, disruption of their routine is not well tolerated by some patients. Literal perceptions make communication challenging. Some patients are nonverbal or struggle to speak under stress. Patients may have involuntary escalation or meltdown. So this may be due to overstimulation, social skill deficits, excessive demands, and unpredictable situations. The patient may know they are out of control, but be unable to regain control efficiently. Basic, keep your instructions basic and use clear, simple, concise direction. Ask basic questions. Use less stuff like radios and other noisy devices. Keep your treatment basic. And assess carefully because the patient may not offer typical complaints. They may not even be able to tell you exactly what's going on or what treatment path to go down. Remain calm. If the patient escalates or melts down, use one-to-one contact accompanied by a caregiver. Keep a clear, controlled tone of voice. Offer empathy and compassion. Allow the patient to express concerns and frustrations, and take extra time. If the situation is not life-threatening, just follow the patient's timeline. This is another situation where utilizing that caregiver that this patient is more comfortable with, almost like a translator, may benefit you. And then safety. Begin treatment where the patient is found. We may struggle to move them, so it's a good idea to begin the treatment where they're found. Remove things that may aggravate the patient. Do a toe-to-head survey, one step at a time. Tell the patient what you will assess next. Communicate with them at a basic level, but you need to make sure that you're communicating with them. Allow time for the patient to ask questions. Consider taking breaks during the exam. Tell the patient or let the patient tell you when they are ready to move on, and avoid restraining the patient. Some medical challenges. Children with lung disease, heart disease, and neurologic disease may live at home with their parents. These children often use medical technologies like tracheostomy tubes and artificial ventilators. The parents and caregivers are typically a valuable source of information about the devices. They have to go through a lot of training through the hospital or doctors before they're allowed to take the patient home on that equipment. Care of these patients is complicated by the lack of history information readily available to the EMT. In my experience, most of the parents and caregivers have a very good history of the patient when they are at home on these devices. Some general considerations with these medical devices at home. When called to a patient with special challenges, you must understand their challenge as well as the chief complaint. Medical advances have enabled many patients with serious conditions to live and work outside of the hospital. As a result, EMTs see many conditions and devices they did not previously encounter. Calls may be related to a problem with the patient's device or for a medical or traumatic problem unrelated to it. So EMTs are increasingly called to assist patients who rely on advanced medical devices at home. So this patient has a feeding line and a home ventilator connected to a tracheostomy. This is not uncommon to see. So there's a variety of healthcare settings. EMTs may respond to calls at private residences, nursing homes, and specialized care or rehabilitation facilities. You should become familiar with any healthcare settings in your community and be prepared for these kinds of calls. Meet and develop plans with faculty representatives. Check whether your community has a program through the dispatch system that identifies people with special devices. For example, we have a senior living apartment in our area, and we keep a list of which apartment and which patient in that apartment has special devices like home oxygen, even if they utilize a walker for ambulating. Knowledgeable caregivers. This can be hit or miss. Sometimes your caregivers, if it's like, in my experience, most children that are taking care of elderly patients are not as good as if it was a child patient and the parent is the caregiver. Those parental caregivers seem to be very knowledgeable caregivers. They have a really good ability to give you a history and chief complaint and everything going on about the situation you're called for. So caregivers are often trained on and very familiar with those advanced medical devices. So some questions to ask caregivers: has this problem occurred before? What fixed it? Have you been taught how to fix the problem? Have you tried to fix the problem, and what happened? Family may also provide insight to the best way to transport the patient. Assign a member of the EMS team to work with a family member on the medical device. Remember that a family member's training may fail when faced with a loved one's emergency. So they may know the day-to-day operations of the device, but in the case of an emergency with that device, they may not be able to help as much. A little gentle coaching may help them overcome their initial stress response. A calm, stable demeanor along with their expertise will lead to a positive outcome. A knowledgeable patient. So the patient may be of help regarding their condition, the need for a device, and the operation of the device. Ask about the device and any problems with it. Your approach depends greatly on the patient's mental status and baseline level of functioning. Always explain what you're doing, regardless of the patient's mental status or condition. So the patient is often an expert on the device or devices that they are depending on. So you can enlist the patient's advice as you discuss their condition, special devices, and the assessments and care you plan to perform. An EMT's actions fall under specific regional and state scopes of practice. Confer with the medical direction if the skill is required, or if the skill required is not something that you are trained or allowed to do. Considerations would include: is the problem with the device life-threatening? Do I have the knowledge to fix the problem? Do I have the supplies needed to fix the problem? And is it within my protocols or within medical direction authorization? Establishing a baseline. Baseline for patients with special care needs often falls outside of traditional norms. So determine what their normal expectations are for the patient, what their normal mental status is, their level of functioning, and determine what changed to make EMS necessary. Patients are often the best source of baseline information, So you can ask what is different about today, why they felt like they needed to call the ambulance. Family and caregivers can also fill in assessment details. They're often well versed in emergency procedures, and they can do things outside of your scope of practice. So as an EMT, you may not be able to change ventilator settings, for example, but if the family's been trained in it, they're not over direct medical oversight. So they can do things that are outside of your scope of practice sometimes. Utilizing those knowledgeable caregivers can greatly benefit you. Use other resources to gain information about a disease or condition. So you can conduct research when the patient is non-emergent or consult medical control for additional information. Don't forget routine care. So differentiate a patient's unique ongoing challenges from routine problems of everyday life. Routine problems may exacerbate chronic conditions. Don't focus so much on the chronic problem that you miss the routine problem. So conduct your standard patient assessment. Life-threatening primary assessment problems are the treatment priority, and then your secondary assessment will help better define the nature of the problem that you're there to treat today. Go over some diseases and conditions. So a congenital disease or condition is present at birth that may or may not be genetic. So there's things like congenital heart disease, cleft palate, and congenital deafness. An acquired disease or condition occurs after birth and may be caused by exposure, trauma, or a medical condition. Things like COPD, AIDS, traumatic spinal cord injury. Some diseases can be either congenital or acquired depending on how they occur. A patient with chronic disease may experience sudden worsening of the disease. A patient may also develop an acute illness. So an acute illness may be more devastating because of coexisting chronic illness. So we'll go through some advanced medical devices. Respiratory devices, there's non-invasive positive pressure ventilation devices. These are the things like CPAP and BiPAP. So CPAP devices blow oxygen under constant low pressure. They prevent collapse of airway passages and are often prescribed for sleep apnea. Biphasic continuous positive airway pressure or BiPAP devices provide inhalation and exhalation assistance. The EMT assessment and transport, patients that use a CPAP at night are unlikely to have emergencies related to the machine. The patient may bring the machine to the hospital. If they think that they're going to stay there, sometimes they'll bring their own device. Alert the hospital personnel of the use of a CPAP device during sleep. If they bring it to the hospital with them and you're giving patient report, you should probably let them know that they brought their own device because they use CPAP due to sleep apnea at night. Tracheostomy tubes. A tracheostomy is a surgical opening through the neck, called a stoma, into the trachea. A tracheostomy tube, or the trach, is inserted into the opening to allow the patient to breathe. A BVM does fit on the end of the tube, and the device that's used to help insert the tube is called an obturator. A long-term tracheostomy may be done for conditions that affect breathing and airway patency. A tracheostomy tube is inserted into the opening to allow the patient to breathe. The patient may or may not use a ventilator and may or may not be able to speak. Mucus buildup is a frequent problem. Dislodgement and stoma infection may also occur. Again, when you have that knowledgeable caregiver, they may know what to do in these situations. The soft tip suction a lot of times is all that it takes. You may have to use a little bit of saline to kind of thin the mucus buildup before you can actually utilize that soft suction to remove the mucus. Check the tube for a blockage. If it's blocked, you can insert that catheter into the stoma. You can determine the depth using that obturator if it's there, or if you meet resistance. You shouldn't have to go in there more than about maybe 2 to 3 inches. Suction as the catheter is withdrawn. So we're not suctioning the entire time from the time we're placing it to removing it. We'll place it, put our thumb over the hole. That's when the suction is going to start, and we will suction on the way out. Cleanse the catheter with sterile water between use. You can use a BVM between suction for ventilator patients, and then transport with the patient's head slightly elevated. Home ventilators. A ventilator is a device that breathes for the patient. It is programmed to take over inhalation, exhalation, timing, and rate of breathing. It is attached to a ventilator circuit that enters the trachea. Common problems are mucus plugs and secretions, infections or respiratory distress, and power or mechanical failures. For EMT assessment and transport, if there are problems with the ventilator, use the DOPE mnemonic. This is a mnemonic that you'll need to remember for the remainder of your career. Displacement of the tube, obstruction or mucus plug, pneumothorax or pneumonia, and equipment problems or failure. So in that order, if we're transporting the patient and they have an issue with the ventilator, it's giving me an alarm, displacement of the tube. So maybe that tracheostomy tube pulled out a little bit, or the cuff deflated, or something along those lines. Simple fix. It's the fastest thing I can do to correct an issue. Obstruction or mucus plug, that could be just the mucus plug, or it could be an obstruction. Probably one of the most common things we see is that the ventilator tubing gets pinched somehow, kind of like a water hose. Pneumothorax or pneumonia, this isn't something that we can do a lot for at the EMT level, but for a pneumothorax, if we find that decreased breath sounds on one side, we can at least make note of that. And then equipment problems or failure. If the equipment fails, we just switch from the ventilator to a BVM. Ensure there is no mucus buildup in the tube. Use a BVM when moving the patient to the ambulance, and then secure the ventilator if you're transporting it. We don't want that heavy equipment to be unsecured in the back of the ambulance while we're moving. Cardiac devices. Implanted pacemakers and cardiac defibrillators. Pacemakers are implanted under the skin with wires attached to the heart. They are designed to prevent the heart rate from becoming too slow. They detect patient activity and modify heart rate accordingly. They deliver a series of low-energy impulses at set intervals to stimulate a faster heart rate. The patient does not feel the impulse. An automatic implanted cardiac defibrillator, or AICD, they are placed under the skin with wires inserted into the heart as well. They are usually implanted in the upper left chest. They detect life-threatening cardiac rhythms. A single shock is delivered when a life-threatening rhythm is detected, but other shocks may follow. If that single shock did not correct the rhythm, the patient may be defibrillated more than once. The patient will feel this and may be upset by the shock. So for assessment and transport, the nature of the call may necessitate ALS. Provide high concentration oxygen and frequently reassess the patient. If the patient goes into cardiac arrest, just use CPR and the AED as indicated. A wearable cardioverter defibrillator. Patients at high risk for dysrhythmias who do not have an AICD may have this wearable cardioverter defibrillator. The WCD works like an AICD to sense dysrhythmias and will deliver a shock. The WCD issues various voice commands to the wearer and bystanders. CPR can be performed on the patient unless the device issues a voice command indicating otherwise. A ventricular assist device. A ventricular assist device is implanted. It's an implanted mechanical pump that takes over the pumping action of the ventricles of the heart. It is literally assisting the ventricles. They move blood from the left ventricle through a tube to a pump implanted in the abdomen. The blood is pressurized and sent back into the circulation. VADs run off of external battery packs connected via a tube through the abdominal wall. Infection, battery failure, and air leakage may occur. So the external battery pack should be secured. Battery failure should be addressed by connecting the pump to an AC power source. If the pump fails, it may have a hand or foot backup. VADs may not generate a pulse. So with a patient with a ventricular assist device, when you feel for a radial pulse, you're probably not going to feel one. But you can listen for pump sounds and assess the patient's visual appearance and mental status. A VAD failure will result in cardiac arrest. This ventricular assist device is there due to how weak the ventricles are. And if that assist device fails, your patient will very, very likely go into cardiac arrest. Here's a picture. You can see the battery pack and everything. I have normally a little harness, like a belt and harness, that holds that battery pack and everything. All right, gastrourinary devices. Feeding tubes are used in patients who are unable to feed themselves or cannot swallow. So there's a nasogastric tube, which is inserted through the nose into the stomach and provides nutrients and removes stomach contents. A gastrostomy tube, or a G tube, that is inserted through the abdominal wall into the stomach. This is longer term nutrient delivery than an NG tube. An NG tube is normally a more temporary placement. Common problems include dislodgement, infection, and clogging. EMT assessment and transport with a feeding tube. You can use tape to secure the tube to the patient's body prior to transport. We don't want a tube that is in place to become dislodged under our care. Keep the nutrient source higher than the tube. If they're still getting the tube feeding, we don't want to place that on the, below the level of the tube entering the body. We want that nutrient source to continue feeding. Put the protective cap in place to prevent leakage. Do not replace a dislodged tube, and place the patient in a seated position if possible. So here's a gastrostomy tube. This is a mother in her kitchen administering a solution to her child through that implanted gastric tube. Urinary catheters are used by patients who have lost the ability to urinate or control when they urinate. So in indwelling Foley catheters, those are the most common type. Most are inserted into the bladder through the urethra and use a balloon to hold the tube in place. External tubing drains to a bag, maybe on their leg if they're up and around, or it may just be on the bed if they're bed bound. Problems with this include infection, blockages, urine discoloration, and dislodgement. There are also like a suprapubic catheter that is inserted through the skin into the bladder, and it's drained the same way. For EMT assessment and transport with a urinary catheter, during transport, keep the catheter bag lower than the patient, but not on the floor. We don't want it to slide around and dislodge. Do not damage the bag with the stretcher. If you have that bag hung on the stretcher when you're putting the stretcher into the ambulance, when those wheels come up from the bottom of the stretcher, they can pinch that bag, and it's not a good day for anyone. Document any urine discoloration or odor. Empty the bag if it is 1/3 to 1/2 full, and then document the amount that's emptied. That may be valuable information for the hospital depending on the patient's complaint. Ostomy bags are connected to the site of a colostomy or ileostomy. Usually they're not visible through the clothing, so unless you're doing a good assessment or the patient tells you, you may not see it. Common problems include infection at the stoma site, blockage, or dislodgement. EMT assessment and transport with a patient with an ostomy bag. Just use care when you're transporting the patient. We just don't want to cause a break or dislodgement of the bag. Dialysis is required by patients who have renal failure. It replaces the functions of the kidneys by removing toxins, filtering blood, and regulating fluid levels. Hemodialysis is the most common. It's performed by an external machine, a dialyzer, usually performed at a dialysis center. Large needles and tubing remove and return blood. Complications with this include bleeding from the AV fistula, infection, and hypovolemia, or a low volume of fluid in your body. Peritoneal dialysis, we are seeing more of this. It requires a permanent catheter implanted through the abdominal wall into the peritoneal cavity. Dialysis solution runs into the abdominal cavity and is ultimately drained back into the dialysis bag. The solution absorbs waste from the body's. Complications include dislodging the catheter and infection. And then this is something that's done at home. The peritoneal dialysis is done at home. EMT assessment and transport of a dialysis patient. Do not take a blood pressure on an arm with an AV shunt, fistula, or graft. Rupture of the shunt, fistula, or graft causes fast, significant blood loss. You can treat this like an arterial bleed. You can use direct pressure. It may even require a tourniquet. Treat for shock, transport, and monitor the patient carefully. Central IV catheters are surgically inserted for long-term delivery of medications or fluids, often used for IV chemotherapy or parenteral nutrition. This is inserted via a surgical puncture to introduce medications or fluids into central circulation. A peripherally inserted central catheter, or a PICC line, has an external tube slightly larger than IV tubing. It's inserted into a peripheral vein and threaded into central circulation. It's often found in the arm, kind of in the bicep area. A central venous line, inserted through a subclavian, jugular, or femoral vein. It may have 1, 2, or 3 external IV tubes attached, normally to the patient's chest. And an implanted port has no external tubing. This is normally found anterior chest. A needle called a Huber needle is needed to access the port. So transporting a patient with these, use of the catheter is restricted to hospital personnel. Be aware of the catheter to avoid tugging or contamination. Do not place an AED pad over any of these lines, and then have a high index of suspicion for sepsis if the patient's presenting with, altered Mill status, lethargy. They've got vital signs that would lead you to believe that they're septic. There's a high index of suspicion for it. A ventriculoperitoneal shunt, or a VP shunt, those are drainage devices from the brain to the abdomen or atrium of the heart, used to relieve excess cerebral spinal fluid. This is common in children with special health needs. If the shunt malfunctions, the pressure in the skull rises. That may cause an altered mental state. The altered mental state may also be due to infection. These patients are prone to seizures and respiratory issues. So the VP shunts are typically done in a patient with hydrocephalus. EMS assessment and transport with a VP shunt. Manage any medical problems as you would for any other patient. Manage airways and prevent hypoxia. Transport and consult medical control for specific instructions. So physical impairments. Take extra time and care to help patients with hearing, sight, or speech impairments. Remember that physical impairment does not mean mental impairment. For patients with hearing loss, ascertain the patient's abilities, write questions and explanations on paper. I don't know how common TDD and TTY phones are anymore. I know in the 90s that was pretty common. Some patients are very capable of reading lips and communicating with some amount of hearing loss. Others, the pen and paper seems to work really well to communicate back and forth. Impairments to sight determine whether the vision is poor or if there is no vision. You can carry a small flashlight in case lights have burned out. Carefully replace any objects that you move. These patients get used to things being in their home a certain way. If they have a significant impairment to sight, if we don't replace those objects, it can cause them to trip and fall, and we're back there for an issue that we caused. You can transport a guide dog, like an actual service animal, with the patient unless it's a threat. If it's an actual guide dog, an actual service animal, those are well trained and should not be a threat. Patients with aphasia or an inability to speak, allow the patient to write or type answers out. Again, the TDD and TYY phones are not really common. Difficulty walking or standing, carefully assess the patient. Bring along any helping devices the patient wants, so a walker or anything. A wheelchair may make assessment more difficult. If the patient is moved to a stretcher, transport the wheelchair safely or secure it from loss. EMT assessment and transport with physical impairments. Provide whatever assistance the patient needs. Assess to determine whether the impairment is the baseline or is a new problem. Determine comfort levels and any tools needed to compensate. Explain your actions and treatments, and when transporting, bring the aids required by the patient. Abuse and neglect. Patients with special challenges are more vulnerable to abuse and neglect due to their dependence on others. Be alert to this possibility during scene size-up, history taking, and assessment. Watch for stories that are inconsistent with injuries, multiple injuries in various stages of healing, repeated injuries, or the caregiver's indifference to the patient. Do not make accusations. Do your best to get the patient out of the environment and report your suspicions according to the requirements of your jurisdiction. If you have a real suspicion, you need to give that report to the hospital facility. They have social workers and all kinds of things that we don't typically have access to. And without you reporting those findings, you were in the home, you witnessed things that the hospital staff is not going to be able to witness. We are required reporters of child and elder abuse. So we need to make sure that we're giving that report to the facility so that they can follow up and do their due diligence to make sure the patient is in a safe environment. Child abuse can take several forms, often in combination. So we have psychological or emotional abuse, neglect, physical abuse, and sexual abuse. What constitutes neglect is a serious legal question. So lack of food, shelter, and a safe environment rarely triggers emergency calls. That may be present, but that may not be what we are called for. So noticing those things during your scene size up is important. Signs of neglect detected during calls for other reasons should be reported to the receiving facility. Physical and sexual abuse are the types most commonly seen by EMTs. Physical abusers may use many objects as weapons. They may beat with a hand or other object. They may burn children with thermal sources, or they may shake, throw, or push children. Sexual abusers may expose themselves or engage in intercourse or even torture. This may result in serious physical injuries. It also causes unseen injuries. Patient assessment for physical abuse, so common findings would be slap marks, bruises, lacerations, abrasions, broken bones, other fractures and fracture complications. Head injuries like concussions or skull fractures, abdominal injuries, blunt trauma injuries, bite marks, burn marks, and indications of shaking in infants. Common indicators of abuse: repeated visits to the same child or children, indications or past injuries, poorly healing wounds and fractures, indications of past burns or fresh bilateral burns, many different injuries to both sides of the body, unusual behavior by the child, and a caregiver who refuses to leave you alone. Observe the adult as you treat the child. Do they seem inappropriately concerned or unconcerned? Do they struggle to control their anger? Do you fear a sudden emotional explosion? Does the adult appear to have deep depression? Are there indicators of drug or alcohol use? And do any of the adults speak of suicide or seek mercy for their unhappy children? Patient assessment for sexual abuse. You can rearrange or remove clothing only as needed to determine and treat injuries. Examine genitalia only if there is obvious injury. Be calm and reassuring. Some common signs would be obvious signs of sexual assault, unexplained genital injury, and seminal fluid on the body or clothes. Remain professional and control your emotions. This is not our job to be involved in anything beyond the care of the patient. Protect the child from any further embarrassment. Do not say anything that makes the child feel like they are to blame. Patient care for sexual abuse. Dress and provide other injury care as needed. Preserve evidence of sexual abuse if suspected. Discourage the child from using the bathroom. Give nothing to the patient by mouth. Do not have the patient wash or change their clothes, and then transport the child. Elders may also be physically, psychologically, financially abused or neglected. Physical abuse includes pushing, shoving, hitting, shaking, and sexual abuse. Physical neglect includes improper feeding, inadequate hygiene care, and inadequate medical care. Psychological abuse and neglect includes threats, insults, and ignoring the elder. And then financial abuse and neglect include exploitation or misuse of belongings or money. Dependent adults outside of pediatric and geriatric populations may also fall victim to abuse and neglect. These adults may have developmental disabilities, physical challenges, or other dependent situations. The approach to recognizing abuse is similar to that used for children and elder adults. Clues come from physical signs like cleanliness and caregiver interaction. Specific warning signs of adult abuse: unexplained absence of caregivers or potentially harmful periods of abandonment, signs of hunger, malnourishment, or improper toileting, improper or unusual interactions with caregivers, caregiver interference with assessment, treatment, or transport. Reporting mandates for dependent adults differ from state to state, so you need to know what your protocols are wherever you're at. The role of the EMT in cases of suspected abuse or neglect: gather information from the caregiver away from the patient without expressing judgment. Talk with the patient separately about how the injury occurred. Control your emotions and provide appropriate care. Do not indicate suspicions of abuse. If a mechanism of injury is suspicious, transport the patient even if the severity of the injury does not necessarily warrant it. EMTs are mandated reporters in some states, I would say most states. Usually reporting requires contacting the state's social service reporting hotline. Notifying hospital personnel or law enforcement may not be sufficient. Even if you're not legally required, reporting is a professional obligation. I feel like that statement's very, very true. Always refer to abuse as suspected or possible. Remain objective and report only the facts. Very, very rarely do we have just blatant proof that it is a fact that the abuse is occurring. So suspected or possible, remain objective and report only the facts. Intimate partner violence. This is a pattern of behavior used to gain control over an intimate partner. It is a pattern of behavior and not an isolated incident. Abusers use physical, emotional, economic, and sexual tactics. EMTs often see the same patients multiple times. EMTs may be the most sophisticated medical care that the patient receives. The abuser may not allow the patient to be transported sometimes. It can be a sticky situation. There are scene safety concerns. If you have to get law enforcement involved, don't hesitate to do so. Sometimes EMTs are the only outlet to social service referral. A lot of services don't work hand in hand with social service, and transporting to the hospital would be the way to make that referral occur. In my experience, there have been times where I've transported the patient along with the abuser. With some professional conversation, I've been able to talk them into going to the hospital, but the highest success rate I've had is by transporting both parties. Assessment of the patient should take place away from the partner and any children. That can be difficult sometimes, but if you've got your partner there, if you can separate the patient and the potential abuser, that makes the assessment go a lot easier. Signs of intimate partner violence: physical signs of abuse, victim fear of talking to EMS or law enforcement, reluctance to accept treatment or transport, obvious isolation of the victim, delays in seeking treatment, history that's inconsistent with injuries, and unusual interactions with the partner. Always attend to medical issues first. These patients often refuse transport due to calculated decisions about their personal safety. Try to be an advocate for the patient. Let them know of community organizations that can help. Note that these services are free and confidential, and point out any 24-hour toll-free hotlines. The EMT's role is to gather information, document statements, and objectively report facts. Human trafficking is the exploitation of a person for compelled labor or a commercial sex act through force. It is a public health issue because it exposes victims to abuse, malnutrition, STIs, and mental health issues. EMTs are uniquely positioned to observe environmental situations that other care providers do not. Some clinical presentations of human trafficking: bruises in various stages of healing, scars, mutilations, or infections due to improper care, urinary difficulties, pelvic pain or pregnancy, chronic back pain, cardiovascular or respiratory problems, poor eyesight or eye problems, malnourishment or serious dental problems, disorientation, confusion, phobias, or panic attacks. Other indicators of human trafficking: the patient is accompanied by a controlling person. The controlling person does all the talking. The patient has a language or cultural barrier. The patient's IDs are being held by someone else. The patient is submissive or fearful. They're inadequately dressed for their job. The patient is subject to security measures. The patient lives in a degraded place or has classical presentations of trafficking. So treat medical issues first. Remember that trafficking is perpetrated by sophisticated and dangerous criminals, so always consider scene safety. Do not disclose your suspicions to others on scene. If the EMT suspects trafficking, law enforcement should be immediately and discreetly notified. Chapter review. Patients with special challenges include those who are homeless or living in poverty, are very obese, have sensory impairments, are terminally ill, have developmental disorders, and/or are technologically dependent. A disability is a condition that interferes with a person's ability to engage engage in everyday activities such as working or caring for oneself. Although patients with special challenges may require EMS for problems related to their disabilities or chronic conditions, do not assume that this is the case for a particular patient. These patients may have the same medical emergencies, an anaphylactic reaction to a new medication, for example, the same as any other routine patient. It is critical for EMTs to treat patients who have special challenges with empathy and respect. The homeless, poor, and very obese are at increased risk for several health problems. When dealing with patients who have autism, use the ABCS mnemonic: awareness, basic, calm, and safety. Patients with special challenges, their families, and their caregivers are often very knowledgeable about the patient's needs and the function of their special equipment. As much as possible, rely on their expertise and involve them in any care. Remember, assistive equipment and special accommodations allow many people with challenges to live normal lives. Beware of overstimulating a patient with an autism spectrum disorder. To ensure proper care, you must recognize, understand, and evaluate the patient's special health care challenges, in addition to presenting the problem or chief complaint that led to the EMS call. Caregivers and patients can provide valuable information about special health challenges and advanced medical devices. A chronic disease or medical condition may present as a primary problem or may complicate another injury or illness. When encountering an advanced medical device, consider what the device is doing for the patient and how important the device is to the patient's survival. Special health challenges often make patients more vulnerable to abuse and neglect. Some questions to consider. What does ABCS stand for when treating an autistic child? What does a CPAP machine do? Can a responder be injured by an AICD that discharges? Critical thinking. You are called to transport a ventilator patient. As you begin your survey, the ventilator stops functioning. What steps should you take to care for this patient? So remembering your DOPE mnemonic: dislodgement, obstruction, pneumothorax, and equipment failure, we can very quickly troubleshoot this issue. If the ventilator stops functioning, first thing you would do, move to the BVM and ventilate your patient that way. You can figure out if there's an issue with the ventilator when your partner is ventilating the patient with a BVM. What transport considerations do you have? To me, this is a patient that could probably be transported to the closest facility as long as it's appropriate for the patient. If the patient had already chosen to go to a hospital that's relatively close, you could just transport there. Remember to make sure that your ventilator, if you're transporting that ventilator, is secured well in the ambulance and not just a free-floating heavy piece of equipment that has the possibility of injuring anybody if you were to get in a wreck, or if that were to fall down because it's not secured and then you dislodge a tube or anything like that. And that's it. Thank you very much for joining.